Excellent. So good morning, afternoon, and evening to those joining us from around the globe. Welcome to today's webinar, Catalyzing Digital Transformation in Healthcare During the COVID-19 Era. Attendees, we appreciate you taking the time out and being with us here today. And of course, a huge thank you to our esteemed panelists in the healthcare space, Dr. Curtis Cole, Chief Information Officer at Weill Cornell Medicine in New York, Adrian Mamen, AVP and Patient Access Transformation Officer at Montefiore Health System, also in New York, and Michael Archuleta, the Chief Information Officer at Mount San Rafael Hospital in Colorado. We are thrilled that you'll be participating in our panel today and really appreciate you joining us. We'll be running a live Q&A at the end of the webinar, so we've enabled our Ask a Question feature via Zoom. It's on the bottom of your screen in the panel. So if you have any questions, just pop them in there. And if you miss anything, no stress, a recorded version of this webinar will be made available later. I'm Aaron Boers, the head of marketing here at Hyro. I've spent about half a decade in emerging technologies with a focus on conversational AI. And today we'll be talking about the way in which COVID-19 and the ensuing challenges presented by a pandemic have expedited digital transformation in healthcare and what the short and long-term effects of that catalysis will be. And before we begin our panel, I'm just going to give a brief background on who we are as a company and how we found ourselves at this intersection of emerging tech, healthcare, as well as a pandemic. So let's jump in. Hyro is a plug-and-play and conversational AI platform that allows healthcare enterprises to quickly add voice and chat capabilities to their digital channels, like websites, apps, as well as call centers. We use strong natural language understanding to enable patients to have these two-way conversations that really simplify their access to information and medical care. We provide frictionless deployment and maintenance processes by automatically building a knowledge graph out of existing content. And that's without any integrations, playbooks, or pesky training data. And that empowers healthcare systems to converse easily, convert more, and ultimately collect actionable patient insights along the way. So how did we find ourselves relevant to COVID-19? Well, we saw the US was poised to be hit hard by the pandemic, and we knew that our type of solution and the speed at which we deploy could really help instantly. We also understood in mid-March from friends, partners, and clients alike in healthcare that health communication channels were about to face a mass spike in traffic without the necessary digital initiatives in place to service those daunting numbers. And this is always a tough graph to look at, especially as an American, but it's important to note where we were a couple of months ago versus where we are in today's webinar. As concern over the spread of the virus grew, high volumes of patients adhering to these social distancing measures and other health regulations were already turning to their health providers' resources, including digital channels, and that created significant backlogs in medical care access as well as testing. In March, the Washington Post even reported a 200% increase in waiting times for call centers and crisis hotlines, and that's only intensified since. Additionally, health regulations led to the disruption of this patient-doctor relationship, and that encouraged the spread of fake news, misinformation, and confusion. Through the Bruno Kessler Foundation, who did a study of 112 million social media posts related to COVID-19, we understood that 40% were coming from unreliable sources. So sourcing validated information for concerned patients had never been more critical. And then solutions to this type of strain on healthcare and patient confusion were started to come in all shapes and sizes. Gartner listed a few main categories in their report about technology innovation in the fight against COVID-19, among them contact tracing, temperature screening, diagnostics, robotics, and virtual assistants, including Hyros. Our free COVID-19 virtual assistant with both voice and text capabilities equips patients with easily accessible information surrounding the coronavirus. The data provided is based on certified resources from the CDC, World Health Organization, as well as the client's own database, if they have one. The assistant also performs symptoms triaging and risk assessment and is up and running in 24 hours. And we've helped answer hundreds of thousands of common questions about COVID-19, like what are the symptoms, how can I protect myself, where can I get tested, and so forth. Beyond aiding patients, we're also arming these healthcare providers with added visibility through conversational insights, so providers can see in real time how patients are interacting with their data and what those patients are asking about. And that's in order to deliver better care. But virtual assistants certainly aren't the only type of digital service to take off during the pandemic. COVID-19 saw the ascension of digital transformation as a whole, particularly for telehealth and e-consultation. I mean, we're talking about increased utilization by 1,500% and higher adoption rates by patients and providers when it comes to virtual engagement across the board. And these are just some of the stats that inspired the theme for today's webinar. And that's what we're going to talk about in depth with our expert panelists. So without further ado, let's begin our fireside chat with Adrian, Michael, and Dr. Cole. I'll ask that each panelist begin with a brief intro about your background and current role. Adrian, if it's okay, let's start with you.
Hi everyone, my name is Adrian Maman. I am the Associate Vice President and Patient Access Transformation Officer at Montefiore Medical Center, which is part of the Montefiore Health System. I've been here for almost 2 years and I have oversight namely of the Patient Access Center, which is the centralized contact center for the organization. Additionally, I sit as part of the faculty practice group, which is an ambulatory arm of the organization where we are trying to help our specialty providers and trying to improve practice operations, and that's not my primary focus, but digital technology and just overall health and welfare of the overall ambulatory enterprise. My background is as performance improvement. In performance improvement in past lives, I've worked in another organization where I've been a master black belt. I've done lean, inpatient and outpatient process improvement, and done a lot in the digital space as well. It's a brief background.
Great. And then I guess we'll move to Dr. Cole.
Hi, so I'm an internist, practice primary care for adults at Weill Cornell Medicine. We are a medical school on the Upper East Side of Manhattan with a practice of about 15 or 1,600 physicians. We do about 2 million visits a year. Our primary affiliate hospitals are New York Presbyterian, the Memorial Sloan Kettering Hospital for Special Surgery. There's many more. After I trained in internal medicine, I did additional training in medical informatics. In the 90s, was part of the project to install the first EMR at New York Hospital. And installed it at Cornell. And now as CIO, I'm responsible for the research, educational, administrative systems as well for the medical school.
Great. And then Michael.
Good afternoon. My name is Michael Archuleta. I'm the Chief Information Officer for Mount San Rafael Hospital. My overall goal has always been, how do we basically incorporate IT as an actual core component to the organizational strategy? I always say that it's not an actual tech makeover, but a business revolution. I'm a technologist, I'm an innovator. We basically are trying to bring technology to really improve better outcomes of what we do moving forward. I think as an organization, it's our duty to basically build strong asynchronous tools that allow our patients to be beneficial both inside and outside of our facility. So again, utilizing technology and business coming together and really trying to come into this new digital age of healthcare where we basically live in. Because my motto always is that hospitals and clinics are digital companies that happen to deliver healthcare services. We're truly living in the digital age of healthcare. Thank you.
Fantastic. Great. So I think we'll start with our line of questioning now, and some of these have been submitted pre-webinar. Some of these are from Hyro, healthcare peers as well. I think, Dr. Cole, I'll start with you. What are some key digital patient access, care, and delivery channels, challenges that were caused by COVID-19?
Well, obviously the big story, as you alluded in your introduction, has been about the massive expansion of telehealth. That presented a whole bunch of interesting problems in and of itself. I think Cornell, like many other institutions, were already very well poised to deliver telehealth, but the adoption was poor because the physicians didn't particularly like it and the reimbursements were terrible. So the regulatory changes under COVID solved that problem, at least temporarily for us, which is why we saw the explosive growth to fill a small gap in the amount of care. But there are many, many others. I think one of the ones that I found the most surprising was actually the need for telehealth in inpatient care. So particularly early in the epidemic, when personally protective equipment, PPE, were in very short supply and had to be rationed, we really needed to minimize the number of people who were taking care of patients. And that meant that if you needed a consultation or other ancillary support that didn't need, where you didn't actually need to touch the patient, that could be delivered by telemedicine, but it had to be done in the inpatient setting. And that presented a variety of complicated problems, not the least of which is that it was not very easy to bill for, but creating integration. I think the long end of the tail that we're beginning to face now with telemedicine, I think it's here to stay, but what we're really seeing is that the digital divide is real. Internet access is a social determinant of health. Video visits are very poorly designed for large groups of the population. They're particularly poor in their multi-language support. So there is a new kind of access gap that we are seeing that the digital tools at both times can help solve, but they also create new gaps that we need to continue to figure out how to solve.
Very interesting, and actually a question we had posed for later in the talk about this digital divide and digital literacy as well. So I think as we move out of the challenges portion of the questions, we'll get back to that subject. It's very interesting. Adrian, I think the appropriate segue is actually to you now. Both you and Dr. Cole, or you and Curtis, were at the center of this crisis in New York. I know Jeff Short, your chief of staff, recently referred to this as the surge. What has been a challenge unique to Montefiore and the location from which you're based?
Obviously, COVID or no COVID, the biggest challenge is our population. We have an 85% payer mix that's mostly Medicare and Medicaid, which is a unique population in and of its own. But as COVID came along, what happened was, we had some true patient access needs. Specifically, patients were reluctant to come into the ambulatory care setting to get the care that they needed. We saw a huge surge in the number of cases that were going up. And then with those cases, a huge decline in our ambulatory volume. And so for us, just like Dr. Cole said earlier, it was really, what can we do to stand up telehealth or shift patients to other ways of providing care. And again, I don't want to just focus on the actual care. It was equally important how we started to engage with patients using other digital channels. So whether it was voice, text, emails, the patient portal, which we wanted to connect with our patients using multiple channels, and then also give them an opportunity to engage with us in multiple channels to, one, get the care that they need, and then secondly, firstly, to connect with us, and then secondly, to get the care that they need.
Right. Great. And Michael, being in Colorado, did you face the same kind of challenges as well? And also, beyond being CIO, I know you're information security officer as well. Was there any added risk or any kind of added issues in terms of security, cybersecurity?
Yeah, absolutely, and that's a good question. So one of my problems that I basically was faced was when the Office of Civil Rights under HHS, when they basically looked at relaxing the enforcement activities of a non-compliant use of public or non-public telehealth services between entities, became kind of a major problem. I think when we look at telehealth, because in my opinion, the acceleration of digital transformation is truly here. And the mass adoption of telecommunicating has been one of the most explosive changes that's truly occurred during this overall pandemic. But the problem is, was your home in order? Meaning, did you have the technology? Did you have the backbone? Did you have your cybersecurity initiatives in place to basically move successfully? Because that became an actual problem. I mean, when we look at these cybersecurity problems, we basically talk about attacks of opportunity. COVID-19 basically became an actual attack of an opportunity, especially with some of the enforcement activities that were basically relaxed under the HHS, having issues with identification management when you're basically trying to implement telehealth. Are you truly keeping your home in order when it comes to strong cybersecurity initiatives? That has become a major problem in the healthcare industry. The healthcare industry has been one of the most attacked sectors out there, and we continue to be attacked because of how valuable PHI basically is. So again, as an organization, cybersecurity has been definitely top of mind, and incorporating information technology and digital transformation as a core component to our overall organizational strategy, as I stated, is not a tech makeover, but a business revolution. At times we forget what does IT mean? Is IT just the individuals basically down in the basement being considered an actual cost center, instead of your actual innovation team really utilizing technology to basically incorporate better outcomes? That's been the problem with our industry, ladies and gentlemen. I'm sorry to say, you know, we look at the natural gas industry, we look at the finance industry, we see these industries 2 years more advanced when it comes to technology initiatives. When we look at the healthcare industry, which we are doing the most important thing in the world is saving patient lives, dealing with patient lives, but we're basically behind the curve in regards to that. We continue to see healthcare being attacked. Again, attacks of opportunity, you know, because we are not incorporating IT as an actual core component to the organizational strategy. When we came into the mix, when COVID hit, I always say, and there's a good saying, is your home in order? And that's basically the bottom line. Is your home truly in order? A lot of healthcare organizations were having problems implementing telehealth. They were having issues with cybersecurity initiatives. There were cybersecurity attacks. There was a lot of high known organizations that were basically being attacked, and a lot of problems. I've known an organization that was a 325 bed level 2 trauma center was basically attacked by ransomware on top of dealing with COVID. That was a major problem, ladies and gentlemen. So again, moving forward, identification management has been a critical component to our overall telehealth initiative. We've also incorporated two-factor authentication to basically allow more enhanced security initiatives in place. We also have always put cybersecurity as the top of mind of anything that we basically do, because cybersecurity is no longer just about data security. It is truly a matter of life and death. And we as an organization, as a healthcare organization, need to continue to basically focus on that culture change, incorporate IT as a core component to the organizational strategy, utilize technology as an actual tool to move forward. Again, hospitals and clinics are digital companies that happen to deliver healthcare services. We are living in the digital age of healthcare. We need to start acting like a digital company.
Wow, fantastic answer, and there's a lot to unpack there. Dr. Cole, do you feel as well that there was or is a lot of red tape around some of these digital initiatives that need to happen? And also, do you feel like some of that red tape has been cut because of COVID-19? And I know you mentioned some of the regulatory changes around some of these initiatives that previously might have been more difficult to deploy. So basically, are there initiatives that you think that are being rolled out now or could be rolled out now that would have otherwise remained unexplored? And do you feel that that red tape again is starting to get cut a little bit?
Yes and no. I think, yes, healthcare is incredibly regulated, but there's also a lot of things in healthcare that are under-regulated. There are many regulations that we run into every day that I think are problematic, but I have a lot of sympathy for policymakers. Policy is a very broad brush with which to paint, and I do believe in security and I do believe in privacy, and it's very hard to get those adopted at a wide scale in industry, in a complex industry, without policy. And when you set policy, you're gonna overstep in some areas. So yes, it's true that with COVID, we got a relaxation of some of the privacy regulations relating to telemedicine, but let's take a look at some of those. So for example, there was a lot of emphasis initially placed on the security of the connections. So they lifted some of the regulations so that you could use more consumer level systems for telemedicine. Okay, I personally don't lose any sleep whatsoever if my faculty are using Apple FaceTime or Apple messaging, because I think they have pretty good security. I would have a heart attack if I found out that they were using WhatsApp. Okay, so both are, you know, backed by trillion-dollar companies. One has a modicum of respect for privacy. One has complete disrespect for privacy. And there's only one entity that can actually resolve that, and that's the government. So, and it's hard to write regulations that do that kind of protection. So one of the things that actually happened to us is that when we moved everybody to remote work, I shouldn't say everybody, because of course the people touching the patients are still touching the patients. But you know, all the back office people, IT, the billers, the people who handle the phones, they're all now in their homes. And we had to relax our security in order to let them into the network so that they could get their work done. So those, you could call that a relaxation of red tape, but it's also a dramatic increase in the attack surface of the institution. So I'm not so excited about the decrement in quote unquote red tape, because some of that red tape needed to exist. You know, HIPAA is a very old law. It's 1997. It needs to be rewritten. It needs to be updated. But it's not just a panacea to say, gee, we just poof, get rid of regulation. And that PS is not what made telemedicine work. What made telemedicine work was that we started paying for it. So if you're going to reimburse a doctor $35 to spend a half hour with a patient on the computer, and you're going to reimburse that same doctor $500 for a 20-minute visit in their office, guess which one we're going to design the system to optimize around? It's going to be the $500. And while it's lovely that we saw an increase in telemedicine visits, and it has been critical to us, we're still hemorrhaging money. Okay, so if you go from 8,000 or 9,000 visits a day that are compensated at several $100s per visit to to 1,000 or 1,500 televisits that are compensated, maybe no longer at $35, maybe you're now up to a couple hundred, you still can't make ends meet. And so yes, it's great that these barriers are falling, but the discussion is only just beginning. And I also should point out that there's still other barriers that have yet to come. So for example, we still don't have parity with the telephone. So a lot of the companies have been focusing on telemedicine as if it means a video visit. And you can't forget that there are a lot of patients who still need to use the phone. They still trust the phone more than they trust video. And they don't have access to video. And it still costs the doctor the exact same number of hours to talk to that patient on the phone. And we still haven't solved that as a pricing barrier. So, so as much as things have gotten better, there's still other problems to solve. So it's both good and bad.
Yeah, for sure. I think the pay divide for telemedicine versus regular physical appointments is actually going to be an interesting topic discussion as things maybe come back to normal. And we'll definitely get back to that as we move along in our line of questioning. Adrian, feel free to piggyback on those thoughts and address those ideas as well. But I wanted to ask you, for Montefiore and you specifically, your department, has this crisis expedited digital transformation for you as a whole? And are there things that maybe would have remained unexplored? And how have your patients reacted to some of those initiatives? So talking from a more patient standpoint about this expedited digital transformation, how is that going to be taken into consideration? And have you seen better adoption and better patient satisfaction with some of these things that you've managed to roll out in the face of COVID-19?
Sure. So for sure, COVID-19 has rapidly increased digital transformation or become the impetus for digital transformation in a more profound way. there's a number of things that we've done. The biggest one is obviously what we've done as it relates to telehealth. We went basically from 0 telehealth visits in January and February and the early part of March to, in the last 12 weeks, we've had about 250,000 telehealth visits, both video and phone. We didn't have a telemedicine video platform, and we stood one up basically in about 10 days. So we're very pleased with what we were able to do in a very short, focused way. The other thing I'll highlight is, we talked about the red tape earlier and about how much red tape there is in organization. Some of that is self-imposed. It is one of my learnings through this. It really is us. And so, when we had the shared goal of overcoming or fighting COVID-19, somehow much of that red tape did go away, right? So now we had this shared vision, this alignment in terms of speed to action, getting things done, necessity, because the alternative would have been empty offices or patients not getting the care that they need. And so some of it is self-imposed and some of it is regulatory, to Dr. Cole's point earlier. And so some of those changes that came from CMS and HHS have really been enablers for some of the great transformative work that has taken place, not just in my organization, but across the country. So I guess from now, the real question is, we're on this journey. I'll say that the appetite has been whet by many stakeholders, both administrators, patients, and physicians alike. And now that we're on this journey, people are desiring more. And so we have whet their appetite, as I said earlier, and hopefully this is the beginning of more to come. And now it's really a question of what are the right priorities? What is our new normal? Will telehealth what is the stake that telehealth is going to have in our new normal? But even beyond telehealth, what are the other, beyond, let's say, direct-to-consumer patient visits, what are the other telehealth features that we may not have turned on, or other ways of providing care, or even other digital transformations beyond telehealth, front door activities, let's say, symptom checkers, triage tools, et cetera, that we can also start thinking about that will improve that patient experience.
That's great. And do you think telehealth, some of those appointments are permanently replaceable by, do you think some of the physical appointments that patients are used to, is replaceable by telehealth?
Yeah, for sure. And I think over time, it'll drive down the cost of care, right? So to some extent, the cost of care are still high because we still have our bricks and mortar sites. We still have payroll for all of the folks that are really meant to care for patients on a face-to-face. But if we shift a proportion in a more focused way, we can drive down some of those other costs, and maybe that disparity in the in-office visit to the office, to the telephone visit or the video visit can be more palpable, or maybe we can get more economies of scale. But I do think it's here to stay. I think that it took us quite a bit of time to get that transition in terms of adoption by both the provider community and also the patient community. I don't disagree that there is a digital divide. I don't disagree that patients don't have access to internet and even literacy, digital literacy, to get themselves online. And so now this is a true social determinant of health, as we said earlier. But we'll overcome those slowly with time. But before, we were definitely at 0% telehealth, or maybe in some organizations that had a little bit more, maybe you had 15%. But since we've kind of gone in very, very quickly and very, very deeply, it may not be at that same level, but I do think that there is a place for telehealth. I think patients have adopted it, and we will start to transition or shift patients from in-office to digital care in a more and more focused way over time. I think it's the new normal.
Well, that's an incredible jump, and you don't need to hear it from me, but really that's quite an accomplishment, how quickly you mobilized and were able to get that service that was non-existent from before, or at least underutilized before, up and running. So that's really something to be proud of. Michael, I'm gonna shift to you now. So what are I want to ask a little bit about some of the key metrics and if those have changed moving from what was normal to the COVID-19 era. So what are some of the key metrics that you know, that are priority for you and that you track, and have those changed since COVID-19?
Yeah, absolutely. So some of our overall key metrics is we continue to basically look at the utilization of telemedicine within the organization. You know, we've truly seen the value of telemedicine for saving time and money. But as an actual CIO, before we start investing more, we need to really maximize the return of investments we've already made and really work with our leaders to hold the gains from virtual visits, which I think is extremely important. So looking at the specific metrics in regards to it, how much are we utilizing the telemedicine? How beneficial how are we doing on reimbursement back to the organization? Do we see some improvements that we can do moving forward? And again, we also look at the way our systems are basically working on an interoperable standpoint. You know, how are we utilizing the continuity of care? How are we sharing information securely and safely? Looking at those specific metrics, how are we seeing our patients basically utilizing the patient portal? Because I think what a critical point is, especially on a strategy, is as an organization, we need to continue to focus on patient engagement strategies. Because I always state that I have a new CEO and my new CEO is a patient. And if we truly want to continue their loyalty, we'll have to earn their trust by by truly knowing them and providing them with the tools that meet their needs. And COVID has really shed light on healthcare needs for digital tools and the importance of a here and now timeline, which have been extremely critical. And as a transformational CIO, as transformational CIOs know, that again, hospitals and clinics are digital companies that happen to deliver healthcare services. We're truly living in that digital age of healthcare, and we need to continue to build those strong asynchronous tools that benefit our patients both inside and outside of the organization. And again, utilizing metrics that focus on patient engagement strategies is extremely important on how are our patients basically engaging with the technology tools that we are implementing to create better outcomes. So those are some areas that we do focus on.
Great. I'll go back now to Dr. Cole. So moving forward, do you believe that this rate of digital adoption for both patients and providers will continue to increase, especially at its current pace? Or do you think that if COVID-19, for instance, were to end tomorrow, that we kind of go back to the more of the status quo and that sort of thing?
Well, I think there's another dimension in there, which is that about 30 million people in the United States have lost their employer-based health insurance. So one of the biggest shifts that's going to occur is that we're going to have to absorb the fact that a lot fewer people can afford healthcare. So that will have a big impact on the overall numeric use of all sorts of different kinds of healthcare. That being said, I certainly agree with everyone else that the shift to telemedicine is permanent in some way, shape, or form, and will continue to be expanded. I don't agree that it's going to lower the cost of care. I actually think it's going to raise the cost of care. And the primary reason, I think it will lower the cost of care that we have been providing in the past. I don't disagree with that because there's care that we used to provide that we will now provide through telemedicine. But we're going to be providing a lot more different kinds of care. So for example, we stopped doing house calls, in the 50s. And now with telemedicine, you can do a house call. So you can do much more frequent follow-up with certain kinds of patients who are hard to get into the office because it was inconvenient. And history has shown throughout the last few decades that whenever we create an innovation in healthcare that we think is going to displace something else, it's usually an and, not an or. That's sort of the typical, at least in this country. I think maybe elsewhere in the world where care costs are contained in slightly different ways, the story might be a little bit different. But I think in the US, we're going to see new ways of using these digital tools to add new kinds of care in places that we haven't seen before.
Great. And Adrian, what are some other emerging technologies maybe that you plan to explore, and why? Maybe also piggybacking off of some of Dr. Cole's points of lowering or increasing the cost of care. So how emerging technologies can help with that, and are any of those motivated specifically by the next potential wave of COVID-19 or the continuance of the first wave of COVID-19, depending on how you look at it?
Right. So one of the things that we did do was stand up a tele-ICU in a very short time. So I think some of those activities, in addition to some of our direct-to-consumer telehealth, is not going to go away. I think right now we're starting to think about what is the new types or the new types of telehealth that we can start bringing into the organization. So provider-to-provider consultations via our hub and spoke model, or maybe what are the various use cases for remote patient monitoring, right? So even if, for example, there's a huge surge, God forbid, but if there is a huge surge and we're in a situation where we don't have as many beds, or we now need to care for patients who are inpatients, let's say at home or in different settings, we can start now thinking about either Bluetooth connected devices or sensors to really care for patients. So that's actually a new opportunity that we're starting to think about. I'll say also additionally, some of these types of care, let's just take sensors, for example, the cost of these equipment are very, very high at this point, right? It may not be palpable for everybody to roll it out in a more focused way. Its adoption increase, and as more people start to use it, the per unit cost will go down. I'm pretty sure of that, and that should drive some of our costs even down, even further. It's really about adoption and engagement. One, adoption and having our physicians accept this new way of doing care, because it is a new way for them and it's a new way for patients as well. And so really engaging patients and getting them to embrace this new technology, and then also starting to think about how we can break down some of those digital challenges in terms of access and internet connectivity. But I do think that the cost will come down even further.
Okay, great. And Michael.
And I'll also add one more thing, I'm sorry.
No, of course.
So it's also about asynchronous, as Michael said, but it's asynchronous and synchronous care, right? So whether it's smart visits, e-visits, using symptom what we call symptom checkers to drive patients to the right outcome. There are options here asynchronously as well as synchronously to drive patients to getting care in different ways than before.
It's an interesting point. And I think throughout this discussion, I'm getting the feeling that there's a balance coming of dealing with that second wave while also trying to go back to delivering care, normal care or pre-COVID care, or however you want to call it. So Michael, I wanted to pose to you the same kind of question, but more, how are you going to use maybe these emerging technologies to, try and prepare for that next chapter while also balancing rebuilding standard practices, recouping some lost appointments, and trying to resume that regular care?
Yeah, absolutely. So in my opinion, artificial intelligence and data analytics are really playing an important role in understanding the spread of the disease, as well as really understanding the effectiveness of the different response to the actual disease itself. We're seeing a lot of researchers really, leverage these types of tools to do everything from tracking hospitals' capacity to really identifying high-risk patients. And I really believe, that these emerging technologies that we're investing in, are really critical to really preparing for similar, situations in the future. Because as we know, healthcare organizations are really now intensifying their focus on a strategic planning for a digital future, and they're really preparing themselves to be ready to launch new initiatives when this crisis passes. So again, you know, there was actually a topic and a discussion I was basically part of, and the topic title was COVID-19 may have just saved U.S. healthcare. So COVID-19 has definitely been a horrible disease and a pandemic, and we've lost a lot of amazing individuals, unfortunately. But this overall COVID-19 has really accelerated transformation within healthcare organizations. Seeing how to utilize the technology to really improve on better outcomes has been just such a critical component. And I think, you know, healthcare has always been, unfortunately, one of those industries that has been behind the curves when it comes to technology advancements. But now we're seeing how incorporating IT to the overall organizational strategy is such an important aspect. And this crisis, again, has fully displayed the value of IT and digital transformation. And out of every crisis, as we know, new opportunity arises. And telehealth has really been one of those key components, you know, to really continue to provide efficient care for our patients. But again, those emerging technology initiatives from artificial intelligence, machine learning, data analytics, these are really critical elements that are basically being leveraged from a high variety, again, from tracking to identifying high-risk patients to really learning from these actual scenarios. And again, it's how is your organization basically going to react if something like this happens? And to rewind a little, IT readiness is such a critical element. I don't care, regardless of the size of the medical institution, IT readiness will be essential for the organization to survive. And that is really a critical point that at times we forget to basically incorporate, because we have always seen IT, and IT, again, technology investments, innovation, have always been one of those items that are basically considered an actual cost center. So organizations, in my opinion, need to see IT as innovators and profit drivers. IT can no longer be considered an actual cost center, but a strategic revenue contributor. And that is a critical element moving forward into the future of the digital age of healthcare, because we are seeing the acceleration of digital transformation during COVID-19.
Wow, I couldn't agree more, and that was very well said. I do believe there are silver linings here, and that's kind of what this webinar is meant to focus on as well, is how such a bad thing can accelerate innovation and transformation that's necessary, change that couldn't wait. Dr. Cole, I'm going to go back to you. Michael mentioned AI, and of course that's a wide range of subtopics within that, but how do you feel about AI within the scope of Weill Cornell Medicine in the next few years, and what will this type of technology especially help you accomplish? And if you want to maybe also pull from Michael's point about, you know, revenue, you know, how can this drive costs down for Weill Cornell as well?
Well, you know, as you said, AI comes in a lot of different flavors and it means a lot of different things. I don't mean to disrespect marketing people, Aaron, but by definition, pretty much any regression analysis that's done in a hospital today is now referred to as AI. If you get past that, there actually is a lot less real, what I would call really hardcore AI happening in healthcare than a lot of institutions are willing to admit. That is not to say that I don't think it has a bright future. We're certainly all in terms of the research program focusing on the development of AI-based tools. I apologize, I can't remember the name of a colleague at Princeton who said, you know, when you advertise for your programmer, it's artificial intelligence, and when you hire them, it's machine learning, and then when you actually build it, it's regression analysis. And if you look at how we actually apply these tools in real life, take, for example, natural language processing. So natural language processing does all sorts of really fabulous things in the consumer space and in certain specific industries. In healthcare, rules-based, boring old, 1970s era, rules-based NLP still outperforms machine learning-based methods in most applications. Now, we all believe that it's going to get there eventually, but healthcare is really hard. The problems that we have are different than in other industries. The data quality issues that we have are very complicated. We don't have gold standards to refer to. It's very expensive to get them. You actually have to hire doctors and things to read things to develop your gold standards. And when you do all of that, you can go from what appears to be a very large data set down to a very small one. And that makes it very hard to actually build these tools in a very robust way. So I totally believe they're going to be helpful, but I don't believe they're a panacea. I also think it's super, super important to remember what they can't do. So AI is not a replacement for, for the randomized double-blind controlled trial. It is not research, okay? It is theoretical. It's wonderful because you can use data with lots and lots of dimensions and kind of see what sticks. But when used incorrectly, which it is a lot of the time, people violate basic rules of statistics. Statistical significance doesn't exist if there was no hypothetical explanation before you did the experiment. So you still have to do experimentation to prove that these things are real and try to understand what they're doing. They do tend to be pretty powerful in the world of prediction, but and possibly even in the area of diagnostics. I won't say possibly, in the area of diagnostics, particularly with imaging. But we also be super careful because they are so fraught with bias. And we just keep seeing that over and over and over again. The melanoma detectors that can't find lesions on black skin. What I tell my students, who I'm trying to actually convince to get into IT, I'm not trying to chase them away, but I do caution them that the next big era that we're going to see is going to be technically imposed iatrogenesis, which is what we call it when we hurt the patient, and so we have to be very, very careful about that. So for us, this is a huge area of investment. It is a very, very big focal point, particularly in the research space. There are a narrow set of clinical applications for it that are emerging, but we have to be very, very careful.
Oh, great points. Yeah, you're right. There's definitely a lot under the umbrella of the AI. And I definitely learned something there about healthcare with respect to AI specifically. So thank you for that. Adrian, so I guess similar question to you, but more from the standpoint of there are opponents of artificial intelligence that argue that while effective, these type of technologies have some downsides. They may lead to job losses. Some of that's been mentioned by Dr. Cole now. But what's your take on that? Is there reason for concern for rolling out these types of initiatives, or do they have more of an upside than a downside? Yeah, you got caught on the mute button there. Yeah.
That's a really, really good question. So, my colleague and I, we kind of jokingly call the technology as force multipliers. So the technology enables us to do more. So as employees, that employee is able to do more. So one way I think about it is we can shift lower acuity work or work that's monotonous or work that doesn't require a lot of skill to be automated using technology. So, we talk about AI, we talk about robotic there's a lot in this space that could be done utilizing technologies, shifting our workers to do more. So they can do more, but in a different way, so that they don't have to be spending their time doing, I don't want to say menial, but simpler tasks that we don't really need highly skilled individuals to do. So it's a shift. I think What it'll enable us to do is care for our patients in a better way, provide enhanced level of service. Yeah, I actually think we'll be able to do more, and things that may have not been done or things that we may not have caught because in some ways the machines are, or AI is better than a human will ever be in some ways, but in some ways they'll never be able to be as good as a human being. And so it's really starting to think about each of those use cases and starting to say which one makes sense for which individual, and I'm saying individual, but a machine is not an individual, but really which one makes sense for each of those scenarios, and start to think about maximizing the opportunity for each of those use cases.
That's great. And in terms of maximizing that opportunity, and I think it was mentioned here by quite a few of you, I think Dr. Cole, you mentioned it first. But Michael, so in order to kind of maximize AI and what it can do in healthcare, in order to deliver that better care through AI and upskill employees like you're talking about, so there are a few channels that, of course, provide that access. Michael, do you think there's an issue with this digital divide, with digital literacy when it comes to that tech savviness? You know, in order to maximize that level of care, how can we bridge that gap? How can we make that divide narrower in terms of, you know, whether it's socioeconomic backgrounds, socioeconomic, or that it's just lack of access, you know, to these digital channels that patients will need in order to experience that leveled up care?
Yeah, absolutely. So, you know, AI is one of those initiatives that really can truly make a difference. And I think when we look at our nation as a whole, we just see several barriers at times, especially when we look at rural America. We look at these critical access facilities. You know, do they have the technology initiatives in place to continue? Do they have the bandwidth technology in place to basically produce, you know, connectivity for actual patients? You know, as we know, AI has been one of those initiatives that really can reduce medical errors and really improve patient outcomes, and in my opinion, improve organizational efficiencies. But the problem is, though, is we still have barriers. We still have issues of truly implementing it, truly creating proof case studies around it, because I think proof case studies is such an important thing. Does it truly work? Is it truly creating better efficiencies for the overall organization? And when we look at technology, you know, we're not really wanting to basically replace an individual. Everyone says, okay, the rise of the bots, you know, it's one of those scary things that we think that robots are going to be taking over. And to a point, you know, we're starting to see artificial intelligence really creating a lot of automation process, a lot of ways to basically improve on patient outcomes, patient efficiencies. How are we communicating without actually using an actual human being? How are we producing the same material to that actual patient itself? I mean, for example, your company, you do an amazing job in regards to an actual bot. You know, utilizing that bot technology with built-in artificial intelligence to basically look at specific algorithms on, you know, what specific questions are being asked. How are we basically providing information to the public? How are we basically displaying what is happening with COVID? How can individuals obtain appointments? I mean, we're really creating better automated processes with the utilization of technology, which again, is an actual tool to improve outcomes. It's been one of those things that we're starting to see AI, predictive analytics, a lot of these different initiatives really come into play. But again, it's really incorporating it into your overall organizational culture, really determining the strong return of investment and the proof case studies of how important or how valuable and how accurate is the actual data that we're basically performing. But again, too, when we're looking at healthcare as a whole, I mean, there's a lot of barriers. You're looking at metropolitan initiatives where technology is different. You're looking at rural America where technology is different. I mean, we're starting to see a huge increase of 5G on how connectivity is basically going to be one of those items, because in the end, when we look at healthcare, we're seeing how do we create better ways of communicating, better ways of interoperability between organizations, between entities. And interoperability has been one of those buzzwords that, I mean, it means so much, different items to different people. But again, I think it's critical that we continue to basically incorporate technology components into the overall organizational's core strategy, which again will take us to a much better place moving forward.
Fantastic. That was a phenomenal answer, and I appreciate you also mentioning us and what we've done so far, at least, to help in that space. I'm going to move. We've got a couple of questions here, and I'm not sure we'll be able to get to all of them. I'm going to start fielding those, and feel free. Either all of you can take it, or one of you, whoever wants to respond. I'm going to start with this one. So we have a question from our audience. Do you see home care being prioritized with patients hesitant to enter the hospital? Aside from telehealth visits, what have your teams implemented to extend that care from in-hospital to at home?
Well, I can take a stab at that. So, I mean, even certainly we are using telemedicine to try to reach out to patients who are afraid to come in. That's absolutely been an essential issue for dealing with care during COVID. Now, it's a Band-Aid. It's a temporizing solution for some people. So if people need actual procedures, if they need chemo, they need something done, they have to come in. But what we can do is, for the things that don't actually have to occur on site, we can try to take care of more of those things at home. So one of the permanent things that I think is going to shift is we are trying to get those awful questionnaires that everybody has to fill out in the waiting room before you see a doctor. We're trying to get those online so that the patients will fill them out before they arrive. To me, that's just a digital version of awful. I'm hoping that we will get even more elaborate with that and actually, get to a point where the computer can actually do a certain kind of basic interview with a patient. And one of the key aspects that could potentially solve, and again, we're not quite there yet, is the ability to try to solve some of the literacy-related problems. So you can give a questionnaire to a college graduate that has many, many questions on a single page, and you will get a reasonably accurate answer. Whereas someone with lower literacy, the exact same questionnaire, you need to space it out. And we've known that about computers for a while, that the computers can actually improve the performance of patients in terms of data collection. So that's the kind of thing that we can do to use the machines to actually enhance care. And some of that's pre-COVID. So for example, when telemedicine wasn't really being reimbursed prior to COVID, we were doing post-operative visits at home. So we have an app, for example, that can do an eye test. So if you get a cataract operation or cornea surgery or something, and you, the only reason you were coming in to the doctor every single day for 10 days after your surgery was for an eye exam, well, you can now do that on an app at home and not have to come in. So to the degree that we can build sensors that can do more of those things, there's one that's been developed that detects edema, for example, swelling in your legs. As we get fancier and fancier with that, we'll be able to do more and more care at home and prevent people from having to come in.
Fantastic. And I think we're basically out of time. I do have one more question. Well, there's a couple of questions here, but there was one that's pretty good that I'd like to ask. Of course, if any of the panelists or attendees have to hop off, I understand. But what is the next digital transformation technology that your health system needs to have in place to be successful in the new normal? That is the last question that I'll ask this panel. So again, Adrian or Michael, if you want to take this one, great.
I think patient engagement is more profound right now, especially given the fear that patients have for coming in, the fact that there's been a reduction in volume and patients have become a little bit more distanced from their healthcare providers. So in terms of patient engagement, Dr. Cole, you mentioned the contactless experience, but I can say take it one step further. whether it's engaging with patients over email, text, voice, however we choose to engage with the patients. We talked earlier about how there's gaps and divides in our patient population, but basically meeting the patients where they are, not necessarily forcing them to adopt or embrace something that they're not comfortable with, but whatever technology that they're comfortable with, meet them where they are to make that new normal. But really it's about not just phones or faxes, but really starting to think about what else we can do in healthcare to engage with patients.
Amazing. Great. I think we are out of time. We do have some other questions here. I will send those to the panelists afterwards, and maybe we can answer those offline. I really want to thank the three of you for taking the time today and talking to us about digital transformation, among other subjects. I hope there weren't too many questions thrown your way. And I just want to say on a personal note that I think it's incredible the job that you've done and the way that you've pulled your organization together throughout these crises and the things you've been able to implement. I'm sure everyone in this webinar has their jaw dropped right now listening to the kind of stories you've told, and I wish you luck and of course good health and safekeeping in the coming months, and hopefully this really will blow over sooner rather than later, of course. So really thank you, Adrian, Dr. Curtis, Cole, Michael. I really appreciate you being here with us today.
Thank you. Take care.
Thank you, guys.
Thank you. And thank you to all our attendees. Bye, everybody.